Good afternoon, everybody. Nice to see you all here again, and some new people, new faces. We're going to do now is kind of shift gears a little bit, and we're going to talk about a really important public health issue in the United States at the moment, which we talked about a little bit yesterday. This is an effort that I've been working on myself for over 2 years. Essentially, what we want to do is do a little bit of an exploration of the use of data, in particular around the opioid misuse and abuse crisis that we have going on in the United States right now. So I'm just going to give you a few numbers about California to kind of orient you. And then we have two gentlemen to talk to us a little bit about the work they've been doing at the national level. So Paul Wormeli, who I think you've met already, the director, let's see, no, that would be me, board member, Stewards of Change Institute, and then Mr. Steve Ambrosini, who's the executive director of IJIS Institute. And I was going to kind of flip from Paul and talk a little bit more from the law enforcement side. And then Justin Erlich, who's the Special Assistant Attorney General in California Department of Justice, the Office of the Attorney General. He's been working on the issue here in California, also a little bit from the law enforcement side. And then Dr. Willis was unable to be here today, but we're ably assisted by Kristen Law, who is a prevention coordinator from Marin County. She's the lead for the community-based prevention team for RX Safe Marin. Those of you who were here yesterday know that's the community coalition working on this issue in Marin. So let me just give you some numbers to demonstrate that California has not been spared from the epidemic of inappropriate use and abuse and, unfortunately, deaths associated with prescription opioid antibiotics. In fact, the age-adjusted death rate for, this is the really boring part of the data. I don't have a story for each of these. But actually the state, we do have a website that has not only all the data for California, but it's also been done by Live Stories. So it really does have stories. I recommend that you have a look at it if you're interested after you've heard this, because you'll be able to see how much more effective that really is than the data alone. But in the year 2006, there were approximately 3 deaths per 100,000 persons in California due to opioids. In 2013, we were up to 3.5. Doesn't sound like a lot, but that's a lot of lives lost over the 38 million people there are in California. And the predominant drugs, well, let me just give you a little bit about the percent increase between 2010 and 2014. This is 4 years difference. For all opioids, the percent of emergency department visits that were related to opioid drugs altogether has increased 44% over the last 4 years. It's increased 35% from other opioids than methadone. So methadone stayed stable. So and that's important, because that's one of the interventions we're trying to use, is increasing the use of prescription-assisted therapies for people with opioid addiction. Amphetamine abuse has increased by 112% visits to the ED. Cannabis 38% and cocaine 11%. So all of those numbers, wrong direction. That's the summary. But also, just so that you know, there's also an interactive map on the website where you can look at each individual county and get the county level data for opioid use. It's a hotspot map, and it goes along with the Live Stories website. That's all I'm going to say about California. So for the moment, I'm going to turn it over to Paul. You can go ahead from right there if you like.
Thank you. We're going to kind of fly you down like an airplane landing from the national level to the state level to the real local problems in Marin County. So I'm going to start with a little bit on what's been going on the national level to deal with what we really believe is an epidemic in this country. It's an epidemic of proportions that we don't even know the extent of. One of the things that happened years ago, California was one of the first states in the country to pass a law requiring the people that sold prescription drugs, controlled substances, to report to the state the sale of those drugs. And the whole purpose of that was to create a capability to track the doctor shopping that was going on and the excessive abuse of substances, and both for substance abuse treatment as well as law enforcement purposes. And during the last 15 years or so, other states have slowly adopted that law to the point now where all states have such a law. But the problem that happened, that we saw developing about 10 years ago, was that even if California was starting to collect this data and we knew the extent to which prescription drugs were being abused in California, there was no way to prevent people from going across into Nevada and getting prescriptions from another 20 different doctors to add to their cash and sell it to their children in their neighborhood or whatever. So our IJIS Institute, working with the Office of the National Drug Control Policy, which was kind of the czar in Washington of drug control, began a project to help states exchange data. And we actually built a prototype between California and Nevada to exchange data with each other on excessive use of prescription drugs. And what was going on even 10 years ago was that 1 out of every 5 middle school children in America were abusing prescription drugs. And that number appears to be increasing. I say appears because this is a great example of the fact that we have a lot of data, but we don't know what's going on. Because there's really no good data to explain the shift that's happening between the prescription drug abuse and street-level heroin, for example. All we do know is that there's been a spike in deaths due to overdose from both of those sources, to the point where many, many of our children on a national level are involved in the excessive use of drugs. The drug quality has changed, the nature of the drugs have changed, and we have a serious problem. Law enforcement agencies, substance abuse agencies, the offices of the federal government, and from the intelligence community to the Office of National Drug Policy, and HHS and DOD, all the federal agencies see that this epidemic is going on, and we just wish we knew what the real extent of it was. So we do know there's a problem, and I'm going to turn it over to Steve to talk about what at least one area is doing to try to get a better handle on this and share the information that we know we need to share.
Thanks, Paul. I'm going to share from a slightly different perspective, but it's really about the same things. It's about the ability to get to the data. It's about the ability to share it effectively. And so I'm going to talk about it a little bit now from the information sharing and information interoperability level. And as Paul said, this has been churning for some time. It started when there were big contentions between the pain management world and the pharmaceutical community, together with something that was being discovered by coroners, really most abundantly in the mid-Atlantic section of the United States. And as we started to see this, and as Paul said, become somewhat of an epidemic, then the Drug Enforcement Agency got involved, and this became now a national initiative. And in 2009, we've been talking here, it really became the largest cause of accidental death in the country. And today, the heroin epidemic costs us about $53 billion, and that's just for the heroin epidemic. And again, we don't have, right now we don't have a way to necessarily validate these numbers, but we know it's significant. In the state of New Jersey, and this also involves some other Northeast states, they're doing this in cooperation with New York, with Maryland, Pennsylvania, Delaware. And what they're trying to deal with right now is, since 2009, is about a 37% uptick in heroin abuse alone. And this has actually coincided with a decline in the fatalities from prescription drug deaths. So we're seeing this sort of, unintended consequence now taking place, because we've been able to put in place the ability for states now to share across state lines on prescription drug abuses. And unfortunately, that has caused well, the good news was, doctors are much more careful about what they're prescribing today, but on the other side, it pushed people towards the heroin, and the unfortunate part of that is heroin is much more economical. It's a fifth of the price, and it's abundant and continues to become even more abundant. And we now have other drugs that are starting to show up with coroners, like fentanyl, which was used as an adulterant for heroin, but now has become a drug on its own. Some of the data sources that New Jersey's been working with they've really emanated from the Governor's Council on alcoholism and drug abuse, but today they're actively tracking coroners' treatment facilities. They do have a statewide prescription drug monitoring program, but this is anchored right now with the New Jersey State Police, and so there's also access to forensics labs and other areas like emergency medical services and hazmat incidents. So they're able to track all of this. The real key has been, though, the ability to work across with the health and human services community, because when Paul talked about Nevada and California, California was the California Department of Justice and Nevada was the Board of Pharmacy. And these aren't two communities that warm up to each other real quickly. And so, yeah, I'm sure you can just imagine. And and sliding across all of this are the same challenges that have been talked about here for the last day and a half. And that's, how do we assure the appropriate use of information on persons? How do we protect that against unauthorized access? All of those things had to be highly trusted in the ability to do that. And if you think about what we're trying to do in all of this effort in interoperability, it's really simple, right? We just want to open a connection to the internet and move data. That should be really easy, but there are things that do kind of get in our way once in a while. And so what this program has really done is really given us an example now with a national implementation of this capability, that these two communities can work together, that we can continue to see the issue does not have to be issues of mistrust or confidence, but that we can have, we can actually put this stuff in place through capabilities to create trust frameworks and some of those things. And so in New Jersey, what they did was they created something called the New Jersey Information Sharing Environment. And this is a platform that is used, it's actually hosted in a cloud, but is used for simply the movement of the transactions. No data stops there, no data sits there. There's no change in residency of data, from any of the organizations that are participating. But there is a trust framework there. There is a credentialing front end to keep unauthorized users from getting into the environment, and then there's a cyber capability that's hosted by the provider, in this case Microsoft, that has their confidence that this information and these transactions can be processed without being breached. So I think where we really found a lot of I guess I'll call it confidence again in moving forward with this, is that this took a lot of that fear away. And fears, again, that's something that's been talked about in the last day and a half. And I had a conversation at our table about the probability of occurrence of something bad happening. But sometimes you can get, you can start thinking about probability in the context of you'll never get attacked by a shark if you never go in the ocean. So I think we we can swim in the ocean. We can do those things without fear of that, really, unlikely occurrence. And we have to be ready to deal with the unlikely occurrence when it happens. And we've seen that happen, and we've seen it not. It doesn't shut everything down. So, just as maybe a couple of things to continue working on as you move forward is that, and Daniel mentioned this earlier, silos are not the enemy. Silos are just what we do to get things done. The answer is being able to federate those silos, to be able to connect them and move data across them. We look at that model now today as the only viable model going forward, because things that are out there, things that are built, I have a new definition of what we call legacy systems, and that definition is they work. So when you have things at work, you don't necessarily want to be shutting them down. So we want to connect them. Policy automation seems to be the biggest challenge today because as we start to look at these things, what's going to give us that confidence again that we can move forward is having the policies in place that you'll be able to withstand, any number of different kinds of challenges. In the law enforcement community today, the biggest is the use of, again, the appropriate use of information on U.S. citizens. And, you've seen, I'm sure, a lot of this in the newspapers, but at the end of the day, you have to be able to answer to the ACLU, you have to be able to answer to your own public policy folks, but that's how you then focus on building those policy automation frameworks. Digital integrity is something you're going to be dealing with because today we're doing more and more and more, and if we're going to get to consent and some of those things, we're doing more and more with digital media than we are with any paper media today. So we can't produce originals anymore, so we have to be able to authenticate and replicate and do it digitally and do it to withstand forensic analysis. And then finally, I just want to make one comment on standardization. We do a lot of work with standards. We know that standards will accelerate our ability to make these things happen. We call it working in the white space. So, I felt the pain of the folks up here earlier about how hard it is sometimes to talk about data. Try talking about standards. Nobody wants to hear it. And, but at the end of the day, it is something that's necessary for us to be able to do this. But there is no one-size-fits-all. So the way we look at standards and the way we look at interoperability is we have to be able to build the profile across the various standards. HL7, and if you've ever heard of the National Information Exchange Model, NIEM, they're both going to coexist. They're going to have to coexist. So we have to figure out how to profile them, across each other and profile them semantically. So it's a big job if you've chosen a good profession to work in. Thank you.
So I'm the Attorney General's advisor on data and technology as a part of the Department of Justice, and grateful to be included in this conversation, particularly since much of our own open data and open justice work has been inspired by and influenced by the great work at HHS. I think we come to this conversation about opioids because for decades, I think starting in the 1930s, we've been collecting data on prescription drugs. It started in a triplicate program, I think, talk about legacy systems. And we have now modernized to Cures as our system, which is the catchy Controlled Substance Utilization Review and Evaluation System. And so we've been doing, collecting a lot of this prescription drug information that, that pharmacists use, that prescribers use, that law enforcement uses. And I think it's sort of moving into a place where we're really excited about, which is a way to share information across the silos that you were just referring to. I think if we take the view from the law enforcement community, it's more and more clear to us that solving a public safety challenge, improving the outcomes of criminal justice means working across silos, working with our sister agencies at HHS, Department of Public Health. And they've shown, and you've shown great leadership in your work here. I think one example being the opioid working group that has been formed, which we're a partner of. And it's really just highlighting the fact that we've collected data for law enforcement purposes that are now really useful and helpful in informing a broader effort around opiates. And so we're excited to be exploring ways to continue sharing that data with other communities to help the broader challenge. We've been working on adding analytics tools and to basically be able to get ahead and do predictive analysis around where there may be issues. And I sort of see the work that we're doing here as a part of sort of a gold standard that can be set across a broader set of public safety issues where we can work across silos, figure out the right ways to share information on a whole set of public safety issues, be it around public health, be it around health and education and criminal justice. So I think all of these things are really linked. if I say legacy systems are working, which is great, and our challenge is to how to get the legacy systems to talk with each other. And what we'll often feel is that may be a technology challenge, how do we get the data to connect? But it's also a political will challenge and a legal challenge of how do we get into a place where we're comfortable sharing, the right legal structures are in place, where we feel comfortable, and it's sort of an environment where we can collaborate. And so I'm really excited about the work that's been done so far and really looking forward to continuing to do that work going forward.
So Kristen's going to show us some slides about RX Safe Marin.
I need this or
Either way, whatever you're most comfortable with.
Okay, so again, I'm not Matt Willis. I have the great benefit of working with community members, and part of my job with the County of Marin is really taking the data that our great epidemiologists collect and helping the community translate it in a way that the other folks in the community will understand. And so I'm not going to go through a lot of these slides because you probably saw a lot of them yesterday when Matt was here. But I did want to say that in Marin County, since probably 2010, if not before then, we've really prioritized community coalitions as a way to address complex public health issues such as substance use. And so when prescription drugs sort of emerged through all these grassroots convenings, we said, well, hey, that's probably the approach we should take. So in 2014, we formed RX Safe Marin. And again, it's a comprehensive public health issue, which requires a comprehensive approach to solving it. And so we were looking at data across all of these different areas and trying to bring people to the table in all of these different areas that you see up here. This is one of my favorite quotes to sort of demonstrate why it's so important to take a collaborative approach to addressing issues such as substance use in a community. So you really need all of these people at the table. And interestingly, when you first bring all these people to the table and you don't have data, they start pointing the fingers and saying things like, well, we just need to reduce the number of prescriptions, or we just need to get more cops on the streets, or what are the schools doing, or bad parenting, or whatever. And then when you have the data to show that it really is comprehensive and that it really is going to take all of these people and that there is no one silver bullet, maybe not even a buckshot, that we all need to be here working together, folks really coalesce around that. So this is sort of our structure of RX Safe Marin, and I think Matt probably went over this already, so there it is again. And our Department of Health and Human Services really provides the backbone for this community initiative. You probably saw all of this too, so here's some of the data sources that we've been using and where we get them from. Here's some more. And I added a few more that I didn't notice in Matt's slides. So we also rely heavily on the California Healthy Kids Survey to look at youth use of prescription drugs. And then I added two more that aren't open data because I think it's part of the story that open data tells some of what we want to know, and then when you show that to the community, they say, well, what about this? Well, what about this? Well, why? Why? And so the community came together in Marin County with our epidemiology department and other folks to get more data. And so I just threw those up there because I think it's an important part of the story. So how did we tell our story? I was really inspired by the last panel because I think that this kind of builds off of some of what was shared. So here's what we create at a health department, right? We love tables and charts and graphs, and this is really beautiful, and there's all these great pages that our epidemiologists put together on how to interpret this data truthfully, because you show a bunch of data to community members, they start making all kinds of their own interpretations. But when we showed it to the community-based prevention action team, they were like, we can't, like, this doesn't tell us anything except for some percentages. We also use live stories, and you can access our live stories report on our website, rxsafemarin.org. But when you ask the community to take the data and to tell a story to the community, they use all kinds of different strategies. So what speaks most to them are those anecdotal sort of pull on the heartstring stories. And so finding affected residents in the community to partner with you to sort of give a face to the data is really important. And Matt's there talking to a father who lost his son and who's been a really great member of our initiative. Oh, this is a different, anyway. So this is a Facebook ad. This is what happens when you take someone else's PowerPoint slide. Surprise. So this is an example of a social media ad. So we have this all over our Facebook. We have paid ad placements, things like this, and it takes you directly to the DEA's website for drop-off sites. We use traditional journalism, so it's not totally dead, and it's a great way to tell your story to a community, especially if you have a higher readership. We use all kinds of different ways to share our stories and to share our data. And so we have a resolution. And for those of you, thank you, who have never written a resolution, it's a great way to incorporate your local data and all the whereas statements. So whereas 1 in 5 11th graders report using prescription drugs for recreational purposes, whereas more people in the community are dying than from car accidents, whereas, and so that's a great way to get it in front of your Board of Supervisors and politicians, Facebook, press releases, things like that. It's just one example. And then here's what our community did with our data. And I think it's just so beautiful. We worked with them to look at all of the data that was on the report card and other places, and they designed these infographics with us. And now we're using them in social media. We have posters in every exam room in our Marin community clinics, and are trying to get it in our Kaiser exam rooms and other exam rooms. So this infographic just shows how many pills are being prescribed in our community and what our goal is RxSafe Marin. Here's another one that just shares myths and facts, and there's data backing every single one of these, and that was really important to the community after we educated them on the importance of having data to back the message. So you're telling the story, but it's truthful. So every every fact has data to back it up, and that's all on our website. This one got the most attention, and partly because of the hormone dysfunction. I don't know why that got so much attention, but we put it on Facebook, and that one got the most clicks and the most likes and the most shares. And again, there's data to back all of that, and the data is not on it, but data informed this infographic. And then here's the last one, and again, this is what the community does when you give them data, and we've had great visibility in our community because of these infographics. And then just some quick lessons learned from doing this, that collecting, interpreting, and disseminating data in a community, a small community like Marin County, really is a collaborative process, and it's really important to bring all of those people to the table to help you tell your story, and also it gets their buy-in in implementing the strategies that your community initiative is going to be taking on. And I know we like to say subject matter experts a lot. For this work, subject matter experts can be anybody. It can be a young person, it can be a parent, it can be your school resource officer, your beat officer. It's not always your public health professional or what have you. So, so you need to get kind of creative with that. For the report card distribution, It was really iterative, and again, we didn't assume that we at the health department were necessarily the experts on interpreting that data and knowing how to get it out into our community to mobilize people to want to be a part of the initiative. It was really an iterative process where we brought all of those people to the table, law enforcement, and we asked them, what does this data mean? Young people, what does this data mean? What solutions should we be taking on in our community because of this data? And then some final conclusions. So understanding that prescription drug abuse requires a coordinated effort because, like I shared, it's a comprehensive issue. And that a report card is just one way that you can sort of synchronize all of these different partners from all of these different places that don't normally work together to focus on a shared priority. So once they were able to see their role in the shared objectives of RxSafe Marin, they were able to say, okay, I'll join your initiative, whereas before there was a lot of distrust and a lot of finger pointing. And again, data can mobilize diverse sectors if you're using your data in new and innovative ways. So showing tables and charts and graphs might really motivate those of us in this room, but they're not necessarily going to motivate the people in the field on the ground doing the work. And there's our website.
Thank you, Kristen. So we accomplished our goal of finishing with the talkie-talkie part fairly quickly in order to leave some time for questions. And I'm going to start it off by, one, telling a little story. See, I was listening earlier. This is my experience working on this particular issue. I knew a lot of the data. I had been working on it at the local level, a little bit with national colleagues. Very familiar with the information, a lot of ideas about kind of how we should work on this, you know, the three-pronged approach that we've taken of decreasing, you know, increasing safe prescribing, giving physicians what they need to understand about how to prescribe, increasing access to medication-assisted therapy for people who are addicted, and then naloxone to prevent deaths and getting naloxone out into the community. And when I first took this job, I went back east for a meeting, met a colleague who was the brand new health officer from Indiana, who told the story of the incredible outbreak that they were having in a very rural part of Indiana, which on average had 1 to 2 cases of HIV a year over the previous 20 years, that suddenly had over 100 cases, same community. And so when they sort of started looking at what had happened there, it was what is now a well-known story, but wasn't really all that well-known at that time, and that was that there had been a lot of prescription diversion into the underground economy, and a lot of young people using prescriptions. They really clamped down in terms of, you know, really giving good direction to physicians on what to, the very few physicians who were actually prescribing in that area, and also law enforcement kind of beginning to use the tools that they had available to try to control doses. And what happened in that young community is that when the prescription drugs were no longer available, or their price rose dramatically, as was mentioned, they turned to heroin because it was very plentiful, it was really cheap. And what happened then was that one individual within this community had HIV, and actually several individuals had hepatitis C, and that was a perfect setup for a massive outbreak, which just completely overwhelmed the resources, not just of that area, but of much of the state. When I came here, I was interested in that particular aspect of this issue and had the opportunity to go to a needle exchange program, a very well-established, excellently run needle exchange program in Sacramento, where I learned from listening to someone else more than I thought I ever knew about this whole epidemic. And what he told me was that they're seeing younger and younger people coming in to their needle exchange to try to get needles, and the clean needles. Those kids are actually the lucky ones, according to what he hears, because most of them don't know to come into the needle exchange. And what's more, what he said is the reason that the folks who've been working in this community and providing access to clean needles for so many years, they're really worried about these kids. And they're worried about these kids, and here was the insight that I hadn't had, because they didn't have older mentors in the injection drug using community to teach them how to inject drugs safely. And so there's been this exchange of dirty needles, exactly what happened in Indiana. And I hadn't made all my data, as much and interesting as that is, all our policy conversations, none of that had the impact on me that realizing that I knew so little about this world that we're risking pushing people into, that it hadn't occurred to me that if you were going to start using injection drugs, it would be a really good idea to know somebody and have as your mentor somebody who'd been doing it safely for a million years. So I throw that out there just to say that no matter what you think you know about an issue, there's always something that you don't know that can really impact you. So with that said, I'm going to turn around and ask the first question, if I may, of either one of you two gentlemen. You had said, Paul, that we don't really have the information we need. If you had sort of a magic computer that would give you whatever information you needed, what do you think would be the single most valuable either data or information that you think would help us kind of move the needle, as we like to say, on this issue?
Well, I think the most valuable thing we could do on that would be to create a mechanism to collect the data from the different disciplines that are counting it. People that overdose from heroin show up in police statistics at times, or they show up in the morgue with the medical examiner statistics, and those two data sets are seldom combined. So we don't even know the extent of this epidemic, if that's truly what it is, and I believe it is, because we don't have a count, and we don't share that data across those disciplines. If there was ever a topic and a social topic that we need collaboration across disciplines, this one is there. The substance abuse community, the medical community, the law enforcement community need to have an ability to share the data on what is going on with this, and it's got to be done quickly, because the kind of example that you used, Karen, of in Indiana can happen anywhere, and it can happen overnight. You know, one heroin addict that's HIV infected and passes a needle around starts a local epidemic that can overwhelm any local system before you can even do it. So we need data and much more close to real time about what's going on, how many people are dying out there, and how can we trace that back in that, like again in the example you used, to the root causes that may have caused that epidemic locally. And the other problem that's close to this and also requires collaboration is the fact that so much of this is young people, as you also mentioned, that the young people that are moving from the abuse of prescription drugs, because we've shut that down more and the price therefore has gone up, moving to heroin, it's a much less controlled environment than the prescription drugs. The same remedies are quite different. You know, in the prescription drug world, you can do things like encourage parents to stop leaving their drugs out in their medicine cabinet, or going after the doctors that are writing thousands of painkiller prescriptions every month. And those kinds of things. That's not how you go after the heroin problem at all. It's a whole different shadowy world that we're not well equipped to deal with. Gil Kurlikowski, when he became the drug czar, the head of the National Office of National Drug Control Policy, and he was a well-respected police chief in Seattle, came to Washington and he said, "The drug war is over, we lost." This is a health care problem, a public health problem, not a crime problem, not a law enforcement problem. And it's not, we have to have that collaboration. And if I did have that magic computer, I'd find ways for the healthcare community, the social services community, and law enforcement to agree on how are we going to share this data? How are we going to come up with collaborative joint solutions to deal with it?
Okay, ready to open it up to folks in the audience?
How can we use data to convince communities to accept facilities such as methadone maintenance clinics? It's my experience that even though there may be an epidemic in the community does not want those facilities in their backyard.
So I'll take a first shot at that unless one of you guys want it. Yeah, I didn't think so. So you're right. Although in my experience, it's not communities per se that don't want it so much as it is law enforcement doesn't want it, and law enforcement's a really powerful reflection of the community. But, and methadone is in particular a real challenge because of the fact that it has to be given continuously. It takes a while. You know, people have to come in, they have to hang out, get the drug, be watched for a period of time and leave, and that really can engender sort of transactions that you'd prefer not to be having in your community. There are some alternative approaches, and in particular, buprenorphine is one approach that most people think is probably preferable to methadone for this kind of issue, and then there are some other drugs that are promising as well. So I think that having the whole panoply of assisted treatment is a better choice than going with one or the other, depending on the circumstance. And that, I think that Kristen would probably echo this. Whatever your messages are, and whatever your interventions are, they really need to fit well in the community that you're wanting to serve. Did you please?
Yeah, I would just add one other thing, which is I think part of sort of conveying the message or understanding the value and impact of holistic care is looking at a set of metrics. So looking at like crime data or other pieces of data that show public safety improvements to highlight that point. So, you know, one reason that we're so passionate about trying to collaborate more closely with the Department of Public Health and HHS is we know that the reason when crime rates jump up, it's not, there are underlying reasons why people are committing crimes. And so if we start going to the root causes of those things, that has a huge impact on public safety. And so there are going to be some trade-offs that are made. More clinics might be involved in certain communities. But if overall we're seeing impact on public safety, that's, I think, part of the message that we all need to do to convey sort of the root value of why we're doing these things.
Yeah, and one thing on the root cause, too, that struck me when you were all speaking, we've been talking about the root cause of, say, an HIV infection that came from an opioid. Haven't really talked very much about why are kids, in fact, using prescription drugs so much, because you have to really back behind that. Why are they increasing? Why are the numbers demonstrating an increase in use? Is it that they're readily available and easy to get, which is what some people would maintain? Is it because they don't have anything to do in the off hours from school? All of the above. And I think in each community, those answers are going to be a little bit nuanced, as well as the interventions that are going to work on those root causes are going to be different in different communities as well. Did you want to say something? You wanted to.
I'm going to talk on both what Dr. Smith said and Justin said, and that is the concept of public safety. And I'm going to move it away from root cause right now, because right now we have a problem that is we haven't even got a cap on yet. And one of the things that we learned in working with this Northeast initiative is they took place-based theory and have displayed where everything is happening. And and the feeds come from, right now, from law enforcement incidents, fire incidents, EMS incidents. They're also coming from the coroners. They're coming from a whole bunch of different places. And they're basically color-coding the maps. And one of the things they discovered was there are 3 counties in New Jersey that have, for some reason, had an extremely high ramp in the heroin abuse. And if we trace it back to everything we're talking about, it's the same thing. It's mostly the increase is young people. Most of them, 65% of them started on prescription drugs, and they don't have that street smarts thing. And so right now they're concentrating everything they can on intervention and prevention efforts in those 3 counties. that gets the attention of the citizens of those 3 counties as well. And that's where we come back to the public safety point, and that is that if communities aren't safe, they stop thriving. And everybody has that, really, I think we all understand that. So there's a problem here right now we just got to get a cap on and continue to work on how we deal with the root cause.
Other questions?
So I want to see if I got a question that I want to try and tie together 2 themes that I've been hearing here. One is, I mean, I think Justin's representation on this panel shows that this issue is bigger than health. It's justice. Arguably, it's education. You could argue, that, and it takes a number of state agencies to come together. And then you've got Marin County, which was really interesting to see what they're doing about engaging with data at a local level. I'm making an assumption that the opioid working group is, and I might be wrong about this, is largely around data. So I think my question is, how are we engaging as well about the tactics that locals need to use to engage with the data? And is that part of what the opioid working group is? And if not, do we have other venues for doing that?
So let me address the working group issue. Some of what we're doing is data. That's one big piece of it is looking at cures, and Department of Justice just got a big award, which you're welcome to talk about, by the way, to improve the accessibility of the cures data for use in by other sectors, in particular by community coalitions that really want to understand what's going on in their community, where, who, as far as prescription opioid use and potential misuse. Also working with medical board, pharmacy board, et cetera, to put out safe prescribing guidelines. So it's not just about data, but the other thing that Department of Public Health is doing, because of this multi-agency working group, we were actually successful in getting a grant from the Centers for Disease Control to do a lot of work. And then one piece of which was in partnership with the California Healthcare Foundation, which is carrying the biggest lift in terms of the money, sponsoring 16 coalitions similar to what Marin is doing around the state. And with a very explicit intention of sharing what each successful coalition has learned about how to work in communities, how to share the information, what interventions are working and what challenges they have with other sort of younger, if you will, coalitions that are just developing. So that's where I think the best information sharing, particularly from coalitions like Marin and San Diego, LA County, that have really had actual not only boots on the ground experience, but have been successful in many ways. And so trying to do that kind of lessons sharing is we hope, going to move that information out more rapidly into other communities. The biggest challenges that we have in the state of California with misuse and abuse of opiate medications, while sheer numbers, as always, put it is in the biggest counties, but the actual population-based rates are highest in our rural, poor, Northern California counties, where the rates are really unacceptably high, I mean frighteningly high. So did you want to say something about it? Did you have anything that you'd like to add?
I'll just add one thing. So as you mentioned, we've been working to upgrade our cures system so it's more user-friendly and accessible to many different communities. And I think in part that is because it acknowledges that the real value of the data is, one, it has to flow back to boots on the ground, people who are doing the work. And so that's really where we're going to unlock a lot of the value. And I think the other is, we think about this a lot at the Department of Justice, is if we rely also on people, locals, to report the data, the best way to ensure that we will actually be getting good data is making it useful for them. And so I think that's part of sort of a vertically integrated data strategy that we're pursuing. And I think you need that sort of circular feedback loop to ensure that long-term the data we have are really going to drive insights.
So
I have one more thing to add really quick, sorry. The only thing I would add is for other communities interested in doing this is is to broaden the scope of folks you're bringing to the table to understand the data, because we learned that, you know, we came in with our narrow sort of interpretation of the data, and when we brought other people to the table, our scope just broadened like we never expected. So I just wanted to make sure I threw that in there.
So in particular, with the issue of prescription opioid abuse, I know that some people have turned to marijuana, medical marijuana, and illegally bought marijuana, people who are seeking pain relief and want themselves a possible alternative without the addictive properties of opiates. And I'm just curious about the thoughts of the panel on that whole issue of the intersection between marijuana use. I know there was some mention today during the panel of drug use, and marijuana was included along with other drugs, and yet this panel is focused on opioid abuse. I myself see the two as different. I'm just wondering about your thoughts about the marijuana movement and where that's going and where it should be going.
Well, I don't think we know yet what that extent of that impact is. There's a lot of research, of course, that you may have read and seen about marijuana being a point of entry into the use of heroin, and that's, you know, been going on in various levels in various places around the country. But I think more studies have been done about that path, which is kind of old news, and that's something that was identified many years ago, and it's still in states that don't have laws permitting medical use of marijuana. That's still a common path, I think. But this is a new phenomenon, to have that alternative of marijuana to prescription drugs. The more you tighten down the availability of prescription drugs or discourage the use, the free availability of prescription drugs to children, they're going to migrate to other drugs if they're so inclined to use drugs, and that could well be a phenomenon that will have to be addressed.
Just quickly add one other point, which I think your question underscores your original story that you started off with, which is we have to see how all of these things link together. So, you know, we've got a public safety balloon, and when we squeeze on one part, a different part, the air moves to a different part. And so this just sort of highlights the need to coordinate. So when we're going after prescription, then we need to be aware of the heroin issue, and then the sort of spikes in crime that will drive. And then we see that the legal regime around marijuana actually has its own impact as we continue to shift forward. So there's both the figuring out how to fix a problem, but also figuring out what future problems that will create, and then trying to get ahead of those in coordination both at the statewide and also working with counties. Just those sorts of things will continue to crop up.
Yeah, and I would say that as long as we continue to look at it just us and not including the people who actually live in the community and see what's happening at the community level, the more we're going to miss some of those areas where the air is going to move in the balloon. So.
Got two more questions.
Okay.
So this is really just addressing through the end the end game where they actually inject heroin as a result. And I just wanted to take this opportunity to plug a different model of syringe exchange, which is the satellite or secondary syringe exchange. We did a model, we evaluated that with our State Office of AIDS with state funding to evaluate a satellite syringe exchange model for some of the sites, and Marin may have been one that we participated in, Humboldt, a few others. And it was very successful for reasons that you mentioned, that they need a peer. Very often people will turn to their peers for like how to inject. And then there's also a lot of prevention material that you can, that are also involved in the program if you actually have more of a formal program. But it's sort of using peers as sort of those outreach workers, but people who are actually like accepted in the group. Especially by the nature of this is where you start with opioids, you're young, you're middle class, you're all these things that may be new to this. And so that's why that model would work best, I think, in these situations. But I also wanted to mention that I think that one of the ways that you can use the open data portal would be, right now we have pharmacies to map maybe some of these pharmacies that are actually providing syringes. So I don't know if that's something that's in the works or not, but at least to have the availability in some of these pharmacies. I don't know if that's been looked at before.
I'm sorry, which kind of pharmacies?
So pharmacies are now able to give syringes.
Oh, yes.
And syringe access through certain pharmacies, but not all pharmacies. They have to obviously agree and go through a program and so forth. So it's not all pharmacies, so we could actually map those in the open data portal and have that available, just as an idea.
Yeah, that's a really interesting idea. I know that local health departments have the ability to find out who's selling clean needles in their communities. We have one last question.
My question goes back to the cross linkages. Sorry. So you had spoken about the opioids, the marijuana linkage, and especially with that particular demographic, the adolescent. The other component, which I think is important to consider, is the impact of e-cigarettes and the fact that they're obviously being provided, and vaping being provided to the younger generation with the same acuity as we saw with the tobacco industry that we fought for how many decades. But that gives an opportunity not only for the delivery of illicit drugs, but also the fact that you're opening a gateway for our adolescent to have all these multifactorial injects. So is there an opportunity to look, especially as we don't have legislation, or the ability to track where many of these shops are developing, how does that interplay with respect to the utilization of the open data, or just having a greater knowledge base or awareness around how all of these injects kind of connect together at a centralized point?
No one's leaping to take. It's an interesting question because it intersects everything from neurochemistry to legislation and policy and retail sales. I think, leave it to say that I think that's an area that's developing. The association between e-cigarettes and opiates or any other drug is really as yet unclear. There's no real science there. So I'm going to leave it at that. Okay, I think we're done. Thank you all very much for your attention. Thank you, panelists.